بسم الله الرحمن الرحيم. أنا الدكتور عمر الكاشف، أستاذ جراحة الأوعية، كلية طب قصر العيني. هنتكلم اليوم عن محاضرة في غاية الأهمية. سبق إن أنا اتكلمت عنها في مؤتمر جمعية جراحة الأوعية المصرية في عام 2024. هذه المحاضرة موجهة بالأساس لجراح الأوعية الدموية أو لجميع الأطباء اللي بيشتغلوا في علاج مرضى انسداد الشرايين. هنشير مع بعض باوربوينت عن المحاضرة دي. As you know, of course, التكرار يعلم الشطار. Our repetition is the secret of learning. So the title is wait a minute before ordering the endovascular suite. Our reference is the basic of vascular and endovascular surgery, written by me. It is a non-profit edition. As you know, atherosclerotic arterial disease may present with either functional ischemia, that is intermittent claudication, or critical ischemia, now termed chronic threatening limb ischemia, CTLI, which may present with wrist pain or with tissue loss, wrist pain or tissue loss in the form of ulcer or gangrene or both of them. So, atherosclerotic peripheral arterial disease produce critical ischemia by either of two mechanisms. The first mechanism is occlusion of sequential bed or occlusion of multi-level disease, as here in the film to the left side there is occlusion of the right common iliac and external iliac disease, together with occlusion of the tibial arteries, occlusion of the peroneal, and occlusion posterior tibial, as it is apparent in this sketch. On the right side film, there is occlusion of the iliac disease and occlusion of the SFA disease. The second mechanism is occlusion of parallel beds. As we see in the film to the left, there is occlusion of posterior tibial artery together with occlusion of anterior tibial artery. Both arteries which can supply the foot are occluded, and so critical ischemia is produced. Or also occlusion of the distal part of posterior tibial, or occlusion of the distal part of the anterior tibial and dorsal pedis, together with occlusion of distal part of the peroneum. So atherosclerotic total occlusion of common femoral artery and its two main branches, superficial femoral artery and profound femoral artery, is considered a parallel bed occlusion. So what is the classical picture of atherosclerosis? In addition to items in history taking as age, diabetes mellitus, smoking, cardiac condition, etc., we have radiological signs of atherosclerosis. These radiological signs of atherosclerosis important. The most important is vessel wall calcification. Calcification is commonly present in X-rays done for patients with atherosclerotic peripheral arterial disease. The second is multi-vessel involvement. It is rare to see a patient with one level occlusion. If we see a patient with one level occlusion, he probably present with claudication, not with a critical limb ischemia, or mixture of focal and diffuse lesion, mixture of focal and diffuse lesion, ostial and proximal vessel involvement, ostial, and proximal visual involvement. So again, what are the radiological signs of atherosclerosis? Visual wall calcification, multivisual involvement, mixture of focal diffuse lesion, ostial and proximal visual involvement. As we see here, this is just a plain X-ray with extensive calcification plain X-ray involving the aorta, the common femur, the superficial femur, part of profunda, and the tibial arteries. So the classical CTA picture of atherosclerosis, as we see, bilateral, diseased arteries, stenosis or occlusion, and multiple levels. It is here also bilaterality, it is the same stenosis and occlusion, diseased arteries, and multiple levels. So the classical picture of CTA of atherosclerosis again is bilaterality, diseased arteries, stenosis or occlusion, not limited to areas of bifurcation. This is the axial cut, which is so important with atherosclerosis of the abdominal aorta below the renal vein, as you see. But atherosclerosis, peripheral arterial disease, is not the only cause of foot ischemia. Although it is true, atherosclerosis is the most common cause. Critical foot ischemia may be the admitting presentation of diseases other than atherosclerosis. In Egypt and parts of the Arab world around us, other causes of critical foot ischemia that should be considered is neglected embolism, still prevalent in Egypt. Arterial embolism, for example, from popliteal aneurysm, thromboangiitis obliterans, Berger disease, other types of arthritis, and other pathologies. So, in Egypt, some other causes of critical ischemia are neglected embolism, arterial embolism, thromboangiitis obliterans, other types of arthritis, and other pathologies. In this case, we see the angiography with normal proximal arteries to the left, embolic occlusion, abrupt occlusion at the area of adductor hiatus, and distal thrombosis in the popliteal and distal thrombosis, as in this report of the CTA. So, it is described in the report that patient proximal superficial artery with abrupt interruption of its lumen at the mid-thigh level. Multiple corpuscle collateral are present. So why the surgeon order endovascular recanalization as if it is an atherosclerotic disease? This case is actually embolic occlusion. So embolism, acute or neglected, is the first conflicting cause in this lecture. In CTA, the key diagnostic finding of arterial embolism are normal proximal arteries, occlusion at bifurcation or stenotic area, for example, the adductor hiatus, distal arteries not apparent in acute phase, as there is no collateral, there is a spasm, and there is distal thrombosis. But again, the most important is high index of suspicion. Again, the most important is high index of suspicion. So in this case, the proximal arteries, the left common iliac and common femur, and the upper two-thirds of superficial femur are normal and no collateral. There is sudden, abrupt, complete occlusion. The distal runoff is not well ossified, thrombosed, and not collateral flow. So in acute embolism phase, the runoff usually not visualized due to distal thrombosis, spasm, or absence of collaterals. But after some time, If neglected, the embolism or in old age due to collateral, the distal runoff may appear again. Again, both atherosclerosis and embolism are different. In atherosclerosis, the classic finding bilaterality disease, the arteries, stenosis or occlusion, not limited to areas of bifurcation. While in embolism, normal proximal arteries, abrupt occlusion, and distal thrombosis. Here also, this is to the left, CTO mid SFA, and it is not embolic occlusion, not at bifurcations. There is multiple stenosis and the distal arteries, disease the distal arteries. More embolism here, normal arteries proximally, occlusion at bifurcation and distal thrombosis. Here also popliteal occlusion with normal arteries on both sides. Here also normal aorta, normal right iliac artery, normal right common, right SFA, right popliteal, and normal tibials, while there is occlusion in the left external iliac at the bifurcation of common femur, abrupt occlusion at bifurcation, and in the axial cut, there is occlusion, complete occlusion of the iliac artery. More embolism, abrupt occlusion, the right common iliac bifurcation, normal other arteries as seen in these films. But this is not atherosclerotic by any means if we apply the previous rule, normal arteries proximal, abrupt occlusion, and normal or occluded distal arteries according to the phase of the embolism. Here also occlusion, the right popliteal bifurcation, and normal other arteries. Multiple sites of embolic occlusion may be present, as here on the right tibioperoneal trunk and in the left popliteal artery embolism, or here on the film to the right, there is occlusion of right popliteal arteries. So we have also multiple sites of embolic occlusion, as here, abrupt occlusion of the left iliac artery, no runoff, or multiple emboli in the film to the right, in the popliteal and the tibial disease. Here also embolism on top of atherosclerosis, abrupt occlusion of the left external iliac artery just after the bifurcation, and in the axial CT to the right, impacted occluding emboli. So why is this confusion occur? Why is the confusion between atherosclerotic disease and the embolic disease occurs? This is because, as before, atherosclerotic occlusive disease is the most common arterial occlusive disease. This is number one. But number two, duplex ultrasound operator always describe atherosclerotic arterial wall in their reports, although in many cases, atherosclerosis is not the culprit pathology. So why is this confusion occur? Because atherosclerotic occlusive disease is the most common arterial disease. Duplex ultrasound operator always described atherosclerotic arterial wall in their report, although in many cases atherosclerosis is not the culprit pathology. How to suspect embolism by the presence of AF, but even with sinus rhythm. Why? Because embolism might be caused by detachment of an already formed thrombus during the phase of passage from AF to sinus rhythm. So the embolism occur in the right atrial appendage during AF non-contractile artery, but detach when the artery resumes its contractile activity with sinus rhythm, as the heart restored its contractile function. The contralateral pedal pulse is felt in most cases. High index of suspicion is needed. So again, how to suspect embolism? Presence of AF or even with sinus rhythm, contralateral pedal pulse is felt in most cases and with high index of suspicion. So as you know, if the atrial thrombus occur in the left atrial appendage, an area of slow flow, and here the left atrial appendage starting thrombosis, a thrombus is formed, and after that, when the heart resumes the sinus rhythm, detachment of thrombus occur and embolism occur. So thrombus formation in the left atrial appendage, embolism, impaction at a site of bifurcation, as you know. In general, absence of AF, atrial fibrillation, is not against the diagnosis of cardiac-arterial embolism. Take care. Absence of AF is not against the diagnosis of cardio-arterial embolism. So before you order the endovascular suite, wait a minute, you may revise or order CTA or MRA. This is especially true if you depend solely on the duplex ultrasound finding with the inexperienced operator, always described atherosclerotic occlusion. In these cases, CTA or MRA is more helpful. History taking is important. Axial cut is not only coronary, as here multiple embolism, multiple site. So in embolism, the patient is young, not diabetic, not hyperlipidemic, even not a smoker. So why to jump to diagnosis of atherosclerotic disease? Again, in a young patient who is not diabetic, not hyperlipidemic, not a smoker, why to jump to diagnosis of atherosclerotic disease? This is an impulse taking the shape of a popliteal bifurcation, taken during surgery for popliteal embolism. The roof axial cut, as I said before, is very important. And this is analysis of one patient CTA. So this patient has a critical stenosis of right SFA. It is diagrammatically represented as occlusion of SFA with a very narrow flow to the eccentric flow, while in the other side there is normal left superficial femoral artery. But axial cut are so important in cases difficult to diagnose, as in this case. In this case, as you see, there is occlusion in the left common iliac and occlusion of the left popliteal and tibial disease. This case was diagnosed as atherosclerotic, but the axial cut helps us to reach to the correct diagnosis. So this is the aortic bifurcation, which is normal in the axial cut. After that, the right common iliac and the left common iliac almost to normal, but starting to be occluded in the left common iliac artery. The left common iliac artery in complete occlusion. The left external iliac artery normal. The left external iliac artery normal. The left common femoral artery normal. The left SFA profunda normal, both of them. The left SFA distally normal, but left B1 is normal and the left B2, but here impacted embolus in B3, left popliteal occlusion, and thrombosed left tibio-peroneal trunk and anterior tibial artery. So looking to the axial cut may help to reach the correct diagnosis in cases difficult to reach this diagnosis. Here is also an X-ray, CTA, and the axial cut of it. So this case is embolic occlusion, occluding the left iliac artery and occluding the left popliteal artery and with thrombosis of tibial artery. Take care, embolism may occur at a different level, but it is abrupt occlusion with normal arteries in between. So why to order endovascular angioplasty for atherosclerotic disease in this case? Axial cut in another case, this is occluded right popliteal artery, while normal left popliteal artery, but in fact embolism may not be cardioarterial. The previous description was about the cardioarterial embolism, but in fact, embolism may not be cardioarterial. Do not forget the arterial embolism. This is a case of left popliteal occlusion, the source of embolism from sacral aneurysm of abdominal aorta. And this is sacral aneurysm of descending thoracic aorta, leading to occlusion of right iliac common femur and left common iliac artery, external iliac artery. So the source of embolism here is sacral aneurysm of the descending thoracic aorta. This is pseudoaneurysm of the femoral artery after angioplasty, coronary or peripheral, which may lead to distal thrombosis. This is a case of traumatic sacral aneurysm of the junction of the right SFA and the B1, and it leads to thrombosis, sacral aneurysm, distal SFA, B1, leading to distal showers in the tibial arteries. So the second conflicting cause after popliteal embolism in general is popliteal aneurysm. So the first conflicting cause was embolism either cardioarterial or arterial, but the second is popliteal aneurysm, which may be the cause of foot ischemia. This is a case of ectasia of B1, aneurysm of B2, and distal showers in the tibial arteries. Embolism versus thrombosed popliteal aneurysm is also important to differentiate by history taking and by examination. So what are the clues to diagnosis? You find the mass in the ipsilateral popliteal fossa, a mass in the contralateral popliteal fossa, a pulsatile mass, of course. So pulsatile mass in the ipsilateral popliteal fossa, pulsatile mass in the contralateral popliteal fossa, contralateral popliteal pulse felt easily than usual. And of course, use the duplex ultrasound and axial cut in CTA. So duplex ultrasound can easily detect popliteal aneurysm as apparent in this record of duplex ultrasound, dilated popliteal artery. Here CTA, which is the main diagnostic tool, on the right side, thrombosed popliteal aneurysm, on the left popliteal aneurysm, non-thrombosed popliteal aneurysm. So in this case, the popliteal aneurysm on the right side is thrombosed, while the left popliteal aneurysm is not yet thrombosed. Remember, easily palpable arterial pulsation on the other side. So CTA is also the main diagnostic tool. Here we have a right popliteal aneurysm. On the other film to the right, we have ectasia or aneurysm in both sides. In this case, we have a small popliteal aneurysm, B2, but the genicular artery is dilated and preventing distal thrombosis. Take care of that. You may find a thrombosed aneurysm but one of the geniculars dilated, giving arterial flow to the tibia, and so there is no distal thrombus. The role of axial cut is important. On the left film, we have thrombosed right popliteal aneurysm with residual patent lumen. As in the diagram sketch, the dilated popliteal artery, and there is a small area of flow inside where the dilated sac was occluded. On the right film, we have bilateral thrombosed popliteal aneurysm. The right completely thrombosed and the left with residual patent lumen. So how can we differentiate between thrombosed popliteal aneurysm and embolic ischemia of popliteal artery by presence of dilated sac of the aneurysm, which is more than normal, while in embolism we find the popliteal artery in its normal size. So axial cut can differentiate between popliteal embolism and aneurysm. In the film to the left, this is an impacted embolus. The popliteal artery is not dilated. There is no sac of popliteal aneurysm. While in the right film, there is a sac of popliteal aneurysm with a small area in flow inside the thrombosed popliteal aneurysm. Duplex ultrasound can also differentiate as seen here. Case 3. This is an important case. Patient presented with a patch of gangrene at the tip of left big toe. It appears like he has an atherosclerosis of the tibial arteries as in this sketch. And so it is a good candidate for tibial angioplasty. This patient, young patient, with a patch of gangrene at the tip of left big toe, CTA, severe tibial disease, which is sketched here, which may be considered a good candidate for tibial angioplasty. But wait a minute. He is not a diabetic. He is of moderate age. He is a male patient. He is a smoker. Angiography, all proximal arteries above both knees are good. No calcification. Again, no calcification. Again, no calcification. So the patient is not diabetic. The patient moderate age is a male patient. He is a smoker. And the angiography revealed that all proximal arteries above both knees are good and have no calcification. So this patient with tibial disease, what is the most correct diagnosis? So this is the third conflicting cause, thromboangiitis obliterans or Berger disease. The third conflicting cause is thromboangiitis obliterans Berger disease. Thromboangiitis obliterans Berger has important features that are distinguishable from other forms of vasculitis. It has highly inflammatory thrombus, relative sparing of blood vessel wall, preservation of internal elastic lamina, normal vessels of acute phase reactant, so you will find normal segmentation rate and CRB, and absent immune activation markers as ANA, RF, and the complement level. The characteristic angiographic finding of thromboangiitis obliterans are involvement of small and medium-sized arteries, the digital arteries of fingers and toes, palmar, plantar, tibial, peroneal, radial, and ulnar arteries. So involvement small and medium-sized arteries, extensive arterial occlusive disease in more than one limb, predominantly the lower limbs, more severe disease distally, segmental occlusive region, diseased arterial segment, intervening normal arteries. So again, sparing of the larger inflow vessels, normal proximal arteries, free of atherosclerosis and with or other sources of emboli, which is important. The occlusion is tapering or abrupt arterial occlusion, collateralization around areas of occlusion described as corkscrew collateral, spider leg, or tree root appearance, which actually is not pathognomonic. See, as we see here, multiple corkscrew distal occlusion. So, what may occur if you tried endovascular recanalization in thromboangiitis obliterans or Berger disease? What may occur? As you see here, this is the distal occlusion, corkscrew appearance in young non-diabetic smoking patient. This will occur, extravasation will occur, and more occlusion will occur, and the patient will be in a very bad situation. Take care, don't do angioplasty and Berger disease or thromboangiitis disease, even if you read some papers which are not put in a randomized controls trial, advising personal experience which we cannot trust in them. Don't do that. So, popliteal tibial bypass with saphenous vein is the most accurate treatment in this case. And this is the CTA after successful popliteal distal bypass. The fourth conflicting cause is vascularitis or arthritis. What type of vasculitis or what types of vasculitis or arthritis can cause lower limb occlusion and foot ischemia? As you know, vasculitis may be large vessel vasculitis, medium vessel vasculitis, a small vessel vasculitis, or ANCA-associated vasculitis, AAVS. But vasculitis or arthritis produce with lower limb ischemia, it is probably large vessel vasculitis. If large vessel vasculitis, it may be giant cell arthritis, or temporal arthritis, or Takayasu arthritis, or Takayasu disease. So this is giant cell arthritis or temporal arthritis, affects the temporal arteries, has no relation with lower limb ischemia. And this is Takayasu arthritis or Bumps disease. To remember it, it usually involves the aortic arch and its branches, affects the more proximal elastic arteries with destruction of the medial elastic fibers. It has certain criteria, three major criteria: left mid-subclavian artery region, right mid-subclavian artery region, characteristic signs and symptoms more than 1 month duration, or multiple 10 minor characteristic as you see in this table. So this is Takayasu involving the subclavian right subclavian artery. But in fact, Takayasu have a rare type which affect the aorta, and it is termed the mid-aortic syndrome, and may affect the lower limb. So Takayasu may be present as mid-aortic syndrome and so affect the lower limb, which is rare. So in this case, why this case is diagnosed as vasculitis? What we have in this case? Normal aorta and iliac artery, abrupt occlusion at the bifurcation of left common iliac, no collateralization, faint run-off. You may think it is one of the rare type of Takayasu affecting the aorta, the mid-aortic syndrome, but the aorta is actually normal, no stenosis or occlusion of the proximal artery. In addition, the other arteries on the other side are normal. So again, normal aorta iliac, abrupt occlusion at bifurcation, no collateral faint run-off. Other conflicting causes may conflict with the diagnosis of atherosclerotic peripheral arterial disease, as here supposed aneurysm of persistent sciatic artery with distal showers. Complete description of this disease will be found in our text basic of vascular and endovascular surgery. So what is persistent sciatic artery? A rare vascular anomaly with persistent embryological access of the lower limb as a continuation of internal iliac artery into the thighs of the great sciatic foramen, below the piriformis muscle, down the thigh along the sciatic nerve. This axial limb artery normally regress after the 12-week of gestation or pregnancy. The sciatic artery may be dominant artery supplying the whole limb, in which case the superficial femoral artery and whole profunda may be the correspondingly small. And another conflicting cause may be popliteal artery entrapment, entrapped by the gastrocnemius muscle, making stenosis. As in this case, it is easily diagnosed by finding good bars with dorsal friction of the foot, but this bars disappear with plantar friction of the foot, or adventitial cystic disease in middle-aged men who have intermittent ring pain and isolated popliteal artery stenosis, but again no other calcium or atherosclerotic disease on CT angiography, as presented here in two forms of the two sketches describing them. Vasculopathy is secondary to connective tissue disease, as Behçet disease or Silk Road disease may be conflicting item, but in Behçet there is ocular lesion or FC, recurrent mucocutaneous lesion, genital ulcer, cutaneous involvement, positive pathology test. Vasospastic disorders as Raynaud's disease, acrocyanosis, livedo reticularis may be conflicting diagnosis. In conclusion, although atherosclerotic peripheral arterial disease is the most common cause of foot ischemia, other causes in Egypt is still not uncommon. So when there is a discrepancy between the patient's symptoms and the diagnostic imaging, when there is a discrepancy between the patient's symptoms and diagnostic imaging, and when there is lack of known atherosclerotic related radiological finding, the possibility of an alternate diagnosis should be considered. So before ordering the endovascular suite and the angioplasty, please consider the other causes of foot ischemia. Use CTA, axial cut in CTA is very important. MRA with axial cut, and keep a high index of suspicion. So our colleagues and students, this is an important topic to consider. Thank you very much for following me. Wassalamu alaikum wa rahmatullah wa barakatuh.